Hello class, this is Emergency Care and Transportation of the Sick and Injured. This is chapter 27, dealing with face and neck injuries. Upon completion of this class, you will have specific knowledge on how to deal with these particular injuries that can cause very fatal outcomes very quickly through air embolus and other varying factors, including also acute and severe bleeding. So that's what we're going to address in this chapter. So here we go. Trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for acutely injured patients. Diseases of the eyes, ears, nose, and throat we will be discussing specifically, along with injuries to those. And among those will be recognition and management of nosebleed. We will be discussing head, facial, neck, and spine trauma, including recognition and management of life threats. And specifically with spine trauma, we're going to also be discussing pathophysiology assessment and management of penetrating neck trauma and laryngotracheal injuries. With spine trauma, we're also going to discuss facial fractures and skull fractures and foreign bodies in the eyes, along with dental trauma. So we're going to be discussing, again, spine trauma, facial fractures, skull fractures, foreign bodies in the eyes, and dental trauma. Now, to introduce these topics, let's talk about this first. The face and neck are particularly vulnerable to injury because of their relatively unprotected positions on the body. Soft tissue injuries and fractures are common and vary in severity. Some injuries are life-threatening, specifically penetrating trauma to the neck that may cause severe bleeding. An open injury may allow an air embolism to enter the circulatory system. If a hematoma occurs in this area, it may stop or slow blood flow to the brain, causing a stroke. With appropriate pre-hospital and hospital care, a patient with a seemingly devastating injury can have a surprisingly good outcome. Now let's discuss anatomy and physiology of the head. The head is divided into the following: the cranium, which is also referred to as the skull, and this is what contains the brain. The brain connects all to the spinal cord through the foramen magnum, which is a large opening at the base of the skull. The most posterior portion of the cranium is called the occiput. On each side of the cranium, the lateral position or the lateral portions are called the temples or temporal regions. Between the temporal regions and the occiput lie the parietal regions. The forehead is called the frontal region. Anterior to the ear in the temporal region, you can feel the pulse of the superficial temporal artery. Now let's discuss the face. The face is composed of the eyes, ears, nose, mouth, and cheeks. The 6 major bones of the face include the nasal bone, the 2 zygomas, 2 maxillae, the mandible, and those are the 6 major bones of the face. The orbit of the eye is composed of the lower edge of the frontal bone of the skull, the zygoma, and the maxilla, and the nasal bone. The bony orbit protects the eye from injury. Only the proximal third of the nose is formed by the bone. The remaining 2/3 are composed of cartilage. The exposed portion of the ear is composed entirely of cartilage covered by skin. The external visible part is called the pinna. The tragus is a small, rounded, fleshy bulge immediately anterior to the ear canal. The superficial temporal artery can be palpated just anterior to the tragus. About 1 inch posterior to the external opening of the ear is the mastoid process, and this is the bony mass at the base of the skull. The mandible forms the jaw and the chin. The jaw is the lower border of the mouth, where the tongue and all 32 teeth are located. The motion of the mandible occurs at the temporomandibular joint, which lies just in front of the ear on either side of the face. Below the ear and anterior to the mastoid process, the angle of the mandible is easily palpated. Now let's talk about the neck. The neck contains many important structures. It is supported by the cervical spine, and the first 7 vertebrae in the spinal column, C1 through C7, are what make up the cervical column in total. The spinal cord exits from the foramen magnum, which is the large opening at the base of the skull, and begins the top of the spinal cord, and the spinal cord itself lies within the spinal canal, which is formed by the vertebra. The upper part of the esophagus and the trachea lie in the midline of the neck. The carotid arteries are found on either side of the trachea, along with the jugular veins and several nerves. Now let's discuss the larynx. The Adam's apple is located in the center of the anterior of the neck. The Adam's apple is the upper part of the larynx. It is formed by the thyroid cartilage. And men and women both have an Adam's apple. It is just more prominent in men than in women. The other portion of the larynx is called the cricoid cartilage, which is a firm ridge of cartilage below the thyroid cartilage. The cricothyroid membrane lies between the thyroid cartilage and the cricoid cartilage. It's a soft depression in the midline of the neck, and there's a thin sheet of connective tissue that joins the two cartilages. The next thing we're going to discuss is the trachea. It is below the larynx, and the trachea connects the oropharynx and the larynx with the main passages of the lungs, the bronchi. On either side of the lower larynx and the upper trachea lies the thyroid gland. The sternocleidomastoid muscles, let me pronounce that again, sternocleidomastoid muscles originate from the mastoid process of the cranium and insert into the medial border of each collarbone and the sternum at the base of the neck. This allows movement of the head. Now we're going to talk about the eye. The eye is globe-shaped and approximately 1 inch in total diameter. It's located within a bony socket in the skull called the orbit. The orbit is composed of 8 adjacent bones of the face and skull. In adults, the orbit protects over 80% of the eyeball because all of those adjacent bones have become fused. In juveniles, those bones have not completed fusion yet. Between and below the orbits are the nasal bone and the sinuses. The figure on this slide illustrates the major components of the eye. Please take the time to review all of these structures of the eye as they are very important. That way, if you have an injury to an eye with a patient, you can write down specifically which areas you observe that you can see that are affected by injury. The eyeball or globe keeps its shape as a result of pressure from the fluid contained within its 2 chambers. A clear jelly-like fluid near the back of the eye is called the vitreous humor. In the front of the lens is a clear fluid called the aqueous humor. In a penetrating injury of the eye, the aqueous humor can leak out. With time and appropriate medical treatment, the body can make more. The conjunctiva is a membrane that covers the eye. It's also pronounced conjunctiva. The lacrimal glands, often called the tear glands, produce fluid to keep the eyes moist. When a person blinks, fluid is swept from the lacrimal glands over the surface of the eye, cleaning it. The tears drain on the inner side of the eye through two lacrimal ducts into the nasal cavity. The sclera is the white fibrous tissue that helps maintain the globular shape of the eye and protects the more delicate inner structures of the eye. On the front of the eye, the sclera is replaced by a clear, transparent membrane called the cornea. This allows light to enter the eye, and the iris is a circular muscle behind the cornea. The iris acts like a camera aperture to adjust the size of the opening and regulate the amount of light that enters the eye. The iris is pigmented, giving eyes their particular color. The pupil is the opening in the center of the iris. This allows light to move to the back of the eye. Anosconia is a condition in which a person is born with different sized pupils. So you might want to bear that in mind. When taking history, if you notice, and the patient is conscious and able to speak with you clearly, if you notice that they have different sized pupils, you might want to ask them if they have normally same size pupils, or if they have anosconia, which is two different size pupils. That's a very important question to ask. In unconscious patients, unequal pupil size may indicate serious injury or illness of the brain or eye. The lens lies behind the iris, and the lens focuses images on the retina at the back of the globe of the eye. The retina contains nerve endings which respond to light by transmitting nerve impulses through the optic nerve to the brain. The retina is nourished by a layer of blood vessels between it and the back of the globe. It's called the choroid. Retinal detachment is when the retina detaches from the underlying choroid and sclera, and it can cause blindness. Now let's talk about specific injuries to the face and neck. Injuries about the face and neck can often lead to partial or complete obstruction of the upper airway. There are several factors that may contribute to the obstruction. There can be blood clots in the upper airway from heavy facial bleeding, and this can lead to complete obstruction, especially in an unconscious patient. Direct injuries to the nose and mouth, the larynx, and the trachea are often the source of significant bleeding and or respiratory compromise. You may need to suction the airway. Injuries may cause teeth or dentures to become dislodged into the throat as well. Swelling that accompanies direct and indirect injury to the soft tissues can also contribute to airway obstruction. The airway may also be affected when the patient's head is turned to the side. This is often the case with altered level of consciousness or unconscious patients. Possible injuries to the brain and or cervical spine may interfere with normal respirations. If the great vessels in the neck are injured, significant bleeding and pressure on the upper airway are common. Here's an example of soft tissue injuries. Soft tissue injuries of the face and neck are very common. The face and neck are extremely vascular, so there's usually a lot of bleeding. Swelling in this area may be more severe. Skin and tissues in these areas have such a rich blood supply that bleeding from penetrating injuries may be heavy. Even minor soft tissue wounds of the face and neck may bleed profusely. A blunt injury can cause a hematoma. Sometimes a flap of skin is peeled back or avulsed. Now let's talk about dental injuries. Mandible injuries are common because of the prominence of the mandible. It is secondly only to nasal fractures in terms of frequency. Most of these fractures are the result of vehicle collisions and assaults. Signs of mandible fracture include misalignment of the teeth, numbness of the chin, an inability to open the mouth, or even close the mouth. Maxillary fractures are usually found after blunt force, high energy impacts. The signs of maxillary fractures include massive facial swelling, instability of the facial bones, misalignment of the teeth, and fractured and avulsed teeth are common following facial trauma. Teeth fragments can become an airway obstruction and should be removed immediately. So do make sure to look for them. Now let's discuss patient assessment. Of course, scene size up is always your first priority, and scene safety is equally important. Upon arrival, observe for hazards and threat to safety to you and your crew. Assess for the potential of violence and environmental hazards. Standard precautions require eye protection and a face mask because of the potential for projectile blood. Place several pairs of gloves in your pockets for easy access. Determine the number of patients and consider the need for additional assistance. Now we're going to discuss mechanism of injury. Make sure to assess the scene looking for indicators of the mechanism of injury, or MOI. Consider how the MOI produced the injuries expected. Common MOIs for face and neck injuries include motor vehicle collisions, sports, falls, penetrating trauma, and blunt force trauma. The primary assessment focuses on identifying and managing life-threatening concerns. Threats to ABCs must be treated immediately. When there is a life-threatening external hemorrhage, it must be addressed before airway and breathing. Make sure to form a solid general impression. Look for important indicators of the seriousness of the patient's condition. Injuries to the face and throat may be very obvious, but may also be hidden by collars or hats, or even scarves. Make sure to control blood loss with direct pressure. Consider the need for manual spinal stabilization. Check for responsiveness using the AVPU scale. In terms of airway and breathing, you want to ensure that there is a clear and patent airway. If the patient is unresponsive or has a significantly altered level of consciousness, consider a properly sized oropharyngeal airway. The nasopharyngeal airway is controversial because of the possibility of insertion directly into the cranial vault and brain tissue if the patient has a facial or head trauma. Be aware of and follow local protocols. Quickly assess for adequacy of breathing. Make sure to palpate the chest wall for decap BTLS. If penetrating trauma is discovered, place an occlusive dressing on the wound. Maintain the airway and provide supplemental oxygen and initiate BVM or bag valve mask ventilation if necessary. Check for breath sounds and provide rapid transport to the hospital if they are abnormal. Splinting or otherwise restricting chest wall motion is contraindicated in this case. Splinting is ineffective and can impair air exchange. We're going to discuss circulation now. You must quickly assess the pulse rate and quality of the pulse. Determine the skin condition, color, and temperature, and also check the capillary refill time. Significant bleeding is an immediate life threat. In terms of transport decision, consider quickly transporting patients with airway or breathing problems or with significant bleeding. Stabilization and maintenance of an airway and breathing, as well as control of bleeding, can be very difficult in patients with facial or neck injuries. Consider ALS backup if the transport time is long. A patient with internal bleeding must be transported quickly for treatment by a physician. Internal bleeding may compromise blood flow to the brain. Bleeding from major vessels of the throat can also impact the patient's airway. Signs of hypoperfusion include tachycardia, tachypnea, low blood pressure, weak pulse, and cool, moist, pale skin. The patient who has significant MOI but whose condition appears to be stable should still also be considered a transport priority. Remember that any significant blow to the face or throat should increase your suspicion of spinal or brain injury. Even if the patient has no signs of hypoperfusion or other life-threatening injuries, there is always the possibility of eye injury. So that is always considered serious, and the patient should be transported to the hospital as quickly and safely as possible. Surgery and/or restoration of circulation to the eye will need to be accomplished within 30 minutes or permanent blindness may result. Now let's discuss history taking. Investigate the chief complaint and obtain a medical history. Be alert for injury-specific signs and symptoms. Also, be aware of any pertinent negatives such as no pain or no loss of sensation. With sample history, attempt to gather this from friends or family if the patient is unresponsive. In unresponsive patients, you will only be able to notice signs of injuries. Information may have to be obtained by someone who is knowledgeable about the patient. Information may or may not be accurate and may be incomplete, so bear this in mind. With secondary assessment, it's much more detailed. Comprehensive examination of the patient is necessary, and that is used to uncover injuries that may have been missed during the primary assessment. You may not always have time to conduct a secondary assessment. With physical examinations, you must remember that there are multiple systems that are likely to have been effective. So start with an assessment of the entire body looking for DCAP BTLS. Perform a detailed examination of specific areas. And do not delay transport to complete a thorough physical examination. In an unresponsive patient who has an isolated injury with a limited MOI, consider focusing your physical examination on the isolated injury and the patient's chief complaint and the body region affected. Ensure that all control of bleeding is maintained and note the location of the injury. Inspect the open wound for any foreign matter and stabilize any impaled objects. During the physical examination, use both your eyes and your hands. Your eyes will be looking for swelling, deformities of the bones, contusions, and discoloration. Your hands will be gently, and I emphasize gently, palpating the face, looking and feeling for any abnormalities. If your patient is if your patient is responsive, you should explain exactly what you are doing and what you are looking for. Your discovery of an abnormality may be an old injury, so make sure to inquire about that in a conscious patient. Assess all underlying systems, including the neurologic system and also including the brain and major nerves. Sensory organs, including the eyes and nose, and also investigate the respiratory system, including the mouth, nose, sinuses, and airway. And the circulatory system, you want to focus on carotid arteries and jugular veins. When evaluating the eyes, start with the outer aspect and work towards the pupils. Examine the eye for any obvious foreign matter. Visual acuity is considered the vital sign of the eye. Gently cover one eye and hold fingers up at arm's length in front of the patient and ask about what they see through their open eye. Test both eyes for the ability to see fingers. Note any discoloration of the eye, bleeding in the iris area, or redness. Also look for eye symmetry because asymmetry indicates a possible brain injury. Look at each pupil for equal size and reaction to light. If pupils are not symmetric, again, as I mentioned earlier, inquire about previous surgeries or injuries, and then also determine whether unequal pupils are caused by physiologic or pathologic issues. Brain injury, nerve disease, glaucoma, and meningitis are all possible causes of unequal pupils. We're going to discuss vital signs now. Assess vital signs to obtain a baseline so you can observe any changes during treatment. You must be concerned with visible bleeding and unseen bleeding inside a body cavity. With facial and throat injuries, baseline information about respirations and pulse is very important. Use of monitoring devices are important, and use appropriate monitoring devices to quantify your patient's oxygenation and circulatory status. You may also use non-invasive methods to monitor blood pressure. Now we're going to talk about reassessment. Repeat the primary assessment. Reassess vital signs and the chief complaint. Continually reassess the adequacy of airway, breathing, and circulation. Recheck patient interventions. This is particularly important in patients with facial or neck injuries because of the ease in which injuries can affect associated systems. The patient's condition should be reassessed at least every 5 minutes. With interventions, you want to provide complete spinal immobilization to any patient with suspected spinal injuries. As far as spinal injuries are concerned, they should be suspected anytime there is significant trauma to the face or neck. Maintain an open airway and be prepared to suction the patient and consider an oropharyngeal airway. Whenever you suspect significant bleeding, provide high-flow oxygen. If needed, provide assisted ventilation using a BVM with high-flow oxygen. Control any significant visible bleeding. If the patient has signs of hypoperfusion, treat the patient aggressively for shock and provide rapid transport. Do not delay transport of a seriously injured patient to complete non-life-saving treatments in the field. With communication and documentation, you must consider the following and use the following. In your documentation, include a description of the MOI and the position in which you found the patient. In cases of motor vehicle crashes, document the method used to remove the patient from the vehicle. In patients with severe external bleeding, it is important to recognize, estimate, and report the amount of blood loss that has occurred. Inform the hospital about all injuries involving the head and neck. Specialists may be needed to manage injuries to the eyes, ears, teeth, mouth, sinuses, larynx, esophagus, or large vessels. With the emergency medical care, you want to treat soft tissue injuries to the face and neck the same as soft tissue injuries elsewhere on the body. Assess ABCs and life-threatening conditions first. Follow standard precautions. In the absence of life-threatening bleeding, the first step is to open and clear the airway. The patient may need frequent suctioning of blood draining into the throat. Avoid moving the neck in patients with suspected cervical spine injuries. Use the jaw thrust maneuver to open the airway and then suction the mouth. Once the patient is immobilized, you can turn the backboard to one side to allow blood or vomitus to drain from the mouth. Control bleeding by applying direct manual pressure with a dry, sterile dressing. Use roller gauze wrapped around the circumference of the head to hold a pressure dressing in place. Do not apply excessive pressure if there is a possibility of an underlying skull fracture. When an injury exposes the brain, eye, or other structures, cover the exposed parts with a moist, sterile dressing. Apply ice locally to injuries that do not break the skin. For soft tissue injuries around the mouth, check for bleeding inside the mouth. Broken teeth and lacerations to the tongue may cause profuse bleeding and obstruction of the upper airway. Often the patient will swallow blood, so the hemorrhage may not be apparent, and patients who swallow blood are very prone to vomiting. Physicians can sometimes graft a piece of avulsed skin back into the appropriate position. So if you find portions of avulsed skin, wrap them in sterile dressing, place them in a plastic bag, and keep them cool. If you have ice, place it on top of the ice with something between the tissue and the ice. Never place the tissue on ice directly because freezing will destroy the tissue and make it unusable. Deliver the bag labeled with the patient's name to the emergency department. If the skin is still attached in a loose flap, place the flap in a position that is as close to normal as is possible. Hold it in place with a dry, sterile dressing. Now we're going to discuss emergency medical care for specific injuries. Injuries of the eyes, we're going to talk about first. Eye injuries are common, particularly in sports. They can produce a lifelong complication, including blindness, so proper emergency treatment will minimize pain and may prevent a permanent loss of vision. In a normal, uninjured eye, the entire circle of the iris is visible. The pupils are round, usually equal in size, and react equally when exposed to light. Both eyes move together in the same direction when following your moving finger, and that is for normal eye function. After an injury, however, pupil reaction or shape and eye movement are often disturbed. Abnormal pupil reactions sometimes are a sign of brain injury rather than eye injury. Treatment starts with a thorough examination. Always use standard precautions and take care not to aggravate any problems. Look for specific abnormalities or conditions that may suggest the nature of the injury. A damaged cornea quickly loses its smooth, wet appearance. Now let's discuss foreign objects. The orbit protects the eye from the penetration of large objects. Even a very small object may produce severe irritation. The conjunctiva becomes inflamed and red, a condition known as conjunctivitis, and the eye begins to produce tears in an attempt to flush out the object. Irritation of the cornea of the conjunctiva causes intense pain. Irrigation with sterile saline solution will frequently flush away loose, small particles. Using a bulb syringe or a nasal airway or cannula to direct saline into the affected eye. Always flush from the nose side of the eye towards the outside to avoid flushing material into the other eye. A foreign body will leave a small abrasion on the conjunctiva. The patient may still report irritation. Gentle irrigation will usually not wash out foreign bodies that happen to be stuck to the cornea or lying under the upper eyelid. If you spot a foreign object on the surface of the eyelid, you may be able to remove it with a moist, sterile, cotton-tipped applicator. Follow the steps in Skill Drill 27-1, but never attempt to remove an object that is stuck to the cornea. Foreign bodies may be impaled in the eye. These must be removed by a physician only. Your care involves stabilizing the object and preparing the patient for transport. Bandage the object in place to support it. Cover the eye with moist, sterile dressings. Surround the object with a donut-shaped collar made from roller gauze or a small gauze pack. Follow the steps in Skill Drill 27-2. When you see or suspect an impaled object or objects in the eye, bandage both eyes with soft, bulky dressings to prevent further injury. The bandage should be loose enough to hold the eyelid closed, but not cause pressure on the eyeball itself. This type of injury must be handled by an ophthalmologist on an urgent basis. Now let's discuss burns of the eye. Your role is to stop the burn and prevent further damage. Chemical burns can occur and are usually caused by acid or an alkaline solution. Flush the eye with water or sterile saline irrigation solution. Direct the greatest amount of irrigating solution or water into the eye as gently as possible. The figures on this slide demonstrate 4 ways to irrigate the eye: a nasal cannula, a shower, a bottle, or a basin. You may have to force the lids open to irrigate. Use a bulb, irrigation syringe, nasal cannula, basin, or running faucet. You can even have the patient immerse his or her face in a large pan or basin of water and rapidly blink the affected eyelid. Flush from the inner corner of the affected eye towards the outside corner. If the burn was caused by an alkali or strong acid, you should irrigate the eye continuously for at least 20 minutes. After irrigation, apply a clean, dry dressing to cover the eye and transport the patient. Now let's discuss thermal burns. During a fire, the eyes will close to protect from heat. Eyelids are frequently burned and require specialized care. Transport promptly without further examination. Cover both eyes with a sterile dressing moistened with sterile saline. You may apply eye shields over the dressing. Now let's discuss light burns. Infrared rays, eclipse light, and laser beams can all cause significant damage to the sensory cells of the eye. Retinal injuries caused by exposure to extremely bright light are generally not painful, but may result in permanent damage. Superficial burns of the eye can result from ultraviolet rays from an arc welder, for example, light from prolonged exposure to a sun lamp, or reflected light from a bright snow-covered area. Now let's talk about lacerations. Lacerations of the eyelids require very careful repair to restore appearance and function. Bleeding may not be heavy, but it is usually controlled with gentle manual pressure. If there is laceration of the globe itself, apply no pressure to the eye. Compression can interfere with the blood supply and result in loss of vision. Follow these important guidelines in treating penetrating injuries of the eye. Never exert pressure on or manipulate the injured globe. If part of the eyeball is exposed, gently apply a moist sterile dressing to prevent drying. Cover the injured eye with a protective metal eye shield, cup, or sterile dressing. Apply soft dressings to both eyes and provide prompt transport. On rare occasions, the eyeball may be displaced from its socket. Do not attempt to reposition it. Cover the eye and stabilize it with a moist, sterile dressing. Cover both eyes to prevent further injury because of sympathetic movement. Have the patient lie supine to prevent loss of fluid from the eye. We're going to discuss blunt trauma to the eye now. These injuries range from an ordinary black eye to a severely damaged globe. Hyphema, which is bleeding into the anterior chamber of the eye, obscures all or part of the iris. It is common in blunt trauma and may cause seriously impaired vision. Cover the eye to protect it from further injury and provide transportation to the hospital. Orbit fracture or a blowout fracture is a fracture of bones that form the eye floor and support the globe. Place this patient on a stretcher and transport immediately. Protect the eye with a metal shield. Cover the other eye to minimize eye movement. With retinal detachment, it's often seen in sports, especially in boxing. It's painless but produces flashing lights, specks, or floaters. It requires prompt medical attention to preserve vision. Eye injuries following a head injury can occur frequently. Any of the following eye findings should alert you to the possibility of a head injury. One pupil larger than the other, eyes not moving together or pointing in different directions, failure of the eyes to follow movement of your finger as instructed, or bleeding under the conjunctiva. You can also have protrusion or bulging of one eye, and for an unconscious patient, keep the eyelids closed. Cover the lids with moist gauze or hold them closed with clear tape. Normal tears will then keep the tissues moist. Now we're going to discuss blast injuries. Signs and symptoms of blast injuries range from severe pain and loss of vision to foreign bodies within the globe. Before responding to patients after a blast, ensure that the scene is safe. Management of the injury to the eye depends on the severity of the injury itself. If there is a foreign body within the globe, do not attempt to remove it. Use a clean cup or similar item to protect the area. If only one eye is injured, follow local protocol. Patients with a sudden loss or decrease of vision will have to be verbally instructed on what is going on around them. This helps keep them calm as well. If the patient has severe swelling or hematoma to the eyelid, do not attempt to force the eyelid open to examine the eyeball itself. Contact lenses and artificial eyes can be something you encounter. In general, do not attempt to remove contact lenses. The only exception is for chemical burns. To remove a hard contact lens, use a small suction cup moistening the end with saline. To remove soft contact lenses, place 1 or 2 drops of saline in the eye, gently pinch the lens between your gloved thumb and index finger, and lift it off of the surface of the eye. Place the lens in a container with sterile saline solution. Advise the hospital staff if the patient is wearing contact lenses. Occasionally, you may find yourself caring for a patient wearing an eye prosthesis. You should suspect an eye of being artificial when it does not respond to light or move in concert with the opposite eye, or appear quite the same as the opposite eye. If you're not sure, ask about it. The figures on this slide show how to remove hard contact lenses and soft contact lenses. So make sure to examine these carefully and just review the process so you don't find yourself trying to do it for the first time in the field and not being sure of what to do. So please examine this chart. Now let's discuss injuries to the nose. Nosebleeds or epistaxis are a common problem. One of the most common causes is digital trauma. Nosebleeds are further categorized into anterior and posterior epistaxis. Anterior nosebleeds usually originate from the area of the septum and bleed fairly slowly. Usually they are self-limiting and resolve quickly on their own. Posterior nosebleeds are usually more severe and often cause blood to drain into the patient's throat. Attempting to insert a nasopharyngeal airway in a patient with a suspected basilar skull fracture or with facial injuries is controversial, so follow local protocols. In fact, I really recommend just not doing it at all if that's a suspected case, because you can cause severe trauma. The nose often takes the brunt of physical assaults and car crashes, and blunt injuries to the nose may be associated with fractures and soft tissue injuries of the face, head injuries, and or injuries to the cervical spine. Assess the nose for injury. It is helpful to picture the inside of the nose itself. The nasal cavity is divided into two chambers by the nasal septum. Both chambers have a superior, middle, and inferior turbinate. Directly above the nose are the frontal sinuses, and on either side, the orbit of the eye. Cerebrospinal fluid, or CSF, may escape down through the nose following a fracture at the base of the skull. Use a piece of gauze to absorb the blood. If CSF is present, the blood will be surrounded by a lighter ring of fluid. This is also called a halo test. Control bleeding by applying a sterile dressing. If the patient is bleeding heavily, it could be the result of significant trauma. Consider cervical spine injury. The patient should not be moved if the airway can be managed in the patient's present position. For a non-trauma patient who is bleeding from the nose, place the patient in a sitting position, leaning forward, and pinch the nostrils together at the base. Now let's discuss injuries of the ear. The ear is complex and associated with hearing and balance. It's divided into three parts. The external ear, which is the pinna or the auricle, and it lies outside of the head. The external auditory canal leads in towards the tympanic membrane, which is the eardrum. Then you have the middle ear, which contains three small bones, the hammer, anvil, and the stirrup, that move in response to sound waves hitting the tympanic membrane or eardrum. The middle ear is connected to the nasal cavity by the eustachian tube, which is the internal auditory canal. The inner ear is composed of bony chambers filled with fluid. As the head moves, so does the fluid. In response, fine nerve endings within the fluid send impulses to the brain about the position of the head. The figure on this slide shows the structure of the ear. So it shows the external, which is the pinna, and the outer ear. It shows the middle ear and then the inner ear. Become familiar with these structures and how they work together. Ears are often injured. but they do not usually bleed very much. If local pressure does not control bleeding, apply a roller dressing. In case of an ear avulsion, wrap the avulsed part in a moist, sterile dressing and put it in a plastic bag labeled with the patient's name. Tympanic membrane rupture can occur, and a sudden change in pressure created by a blast wave may cause tympanic rupture, for example. Patients will report severe pain, difficulty hearing, or ringing in the affected ear. Tympanic membrane rupture may also be caused by insertion of objects too far into the ear. Patients with suspected tympanic membrane injury should be transported to the hospital for evaluation. Children often place foreign bodies in the external auditory canal. All foreign bodies should be removed by a physician. Do not try to manipulate the foreign body because you may end up pushing it further into the ear. Clear fluid that's coming from the ear may indicate a skull fracture. Now let's talk about facial fractures. These typically result from blunt impact, and you should assume that any patient who has sustained a direct blow to the mouth or the nose has a facial fracture. Other clues include bleeding in the mouth, inability to swallow or talk, absent or loose teeth, or loose or movable bone fragments. Facial fractures alone are not acute emergencies unless there is serious bleeding. In addition to external hemorrhage, there is the danger of blood clots lodging in the upper airway and causing an obstruction. Plastic surgeons can repair the damage to the face and mouth if the injuries are treated within 7 to 10 days. Remove and save loose teeth or bone fragments from the mouth because it is often possible to replant them. Remove any loose dentures or dental bridges to protect against airway obstruction. Another source of airway obstruction is swelling, which can be extreme within the first 24 hours after injury. Now let's talk about dental injuries specifically. Dental injuries can be traumatic to the patient. The injury may be traumatic to the patient's permanent teeth, and they may be lost. It can affect everything from eating to smiling. Bleeding will occur whenever a tooth is violently displaced from its socket. Apply direct pressure to stop the bleeding. Perform suctioning if needed. Cracked or loose teeth are possible airway obstructions as well. Save and transport an avulsed tooth, handling it by the crown and not by the root. Place the tooth in tooth storage solution, cold milk, or sterile saline. Notify the receiving facility of avulsed teeth. Reimplantation is recommended within 20 minutes to 1 hour after the trauma. Now, injuries to the cheek are something that you may encounter, and you may encounter an object that is impaled in the patient's cheek. If you are unable to control the bleeding and it compromises the airway, you may have to consider removing the object. Then provide direct pressure once it's removed on both the inside and outside of the cheek. The amount of bandaging should not be so overwhelming that it occludes the mouth and makes it difficult to breathe. Now, injuries of the neck. The neck contains many structures vulnerable to injury by blunt trauma, including the upper airway, esophagus, carotid arteries, and the jugular veins, the thyroid cartilage, which is the Adam's apple, cricoid cartilage, and the upper part of the trachea. First, we're going to discuss blunt trauma to the neck. Any crushing injury of the upper part of the neck is likely to involve the larynx or trachea. Examples include collision with a steering wheel, attempted suicide by hanging, clothesline injuries sustained while riding a bicycle, and once the cartilages of the upper airway and larynx are fractured, they do not spring back to their normal position. Injuries to the neck can lead to loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, and leakage of air into the soft tissues of the neck. Subcutaneous emphysema is a characteristic crackling sensation produced by the presence of air in the soft tissues of the neck. If you feel this when palpating the neck, maintain the airway as best you can and transport immediately. Complete airway obstruction can develop very rapidly. ALS support either by air or intercept may be necessary. It is possible that these incidents involving an injury to the throat may also have caused a cervical spine injury. Spinal immobilization may be needed. In fact, it's more than likely recommended. Now let's discuss penetrating injuries. Penetrating injuries to the neck can cause profuse bleeding from laceration of the great vessels in the neck. Injuries to the carotid arteries and the jugular veins in the neck can cause the body to bleed out, also known as exsanguination. Injuries to these large vessels may also allow air to enter the circulatory system. If a vein has been punctured, air may be sucked through it into the heart. This condition is called an air embolism. A large amount of air in the right atrium and right ventricle of the heart can lead to cardiac arrest. The airway, the esophagus, and the spinal cord can be damaged by a penetrating injury. Direct pressure over the bleeding site will help control most neck bleeding. Follow the steps in Skill Drill 27-3. You may find it necessary to apply pressure above and below the penetrating wound to control life-threatening bleeding. Maintain cervical spine immobilization if indicated. Now let's discuss laryngeal injuries. Laryngeal injuries occur when there is blunt force trauma to the larynx, and this can occur, for example, when an unrestrained driver strikes a steering wheel, a snowmobile rider or an off-road biker strikes a clothesline or fixed wire, or sometimes even like a tree branch. The larynx becomes crushed against the cervical spine, resulting in soft tissue injury, fractures, and/or separation of the fascia. These strangulation injuries can also be found in either intentional or unintentional hangings. Anytime there is a suspected injury to the larynx, suspect possible cervical spine injury. Penetrating or impaled objects in the larynx should not be removed unless they interfere with the cardiopulmonary resuscitation. Stabilize all impaled objects if they are not obstructing the airway. See Skill Drill 26-1 from Chapter 26, Soft Tissue Injuries. Significant injuries to the larynx pose immediate risk of airway compromise. Signs and symptoms of larynx injuries include respiratory distress, hoarseness, pain, difficulty swallowing, which is also known as dysphagia, cyanosis, pale skin, and sputum in the wound. You can also develop subcutaneous emphysema, bruising on the neck, hematoma, bleeding. To manage a laryngeal injury, make sure to provide oxygen and ventilation. Apply cervical immobilization, but avoid the use of rigid collars. Okay, class, that is the entire chapter, so now we're going to go through our review questions. And here's our first review question. Number 1. Which of the following statements regarding the Adam's apple is false? A. It is inferior to the cricoid cartilage. B. It is formed by the thyroid cartilage. C. It is uppermost part of the larynx. Or D. It is more prominent in men than women. Again, which one of these is false? It is A. The most obvious prominence in the center of the anterior neck is the Adam's apple. This prominence is the upper part of the larynx formed by the thyroid cartilage. It is more prominent in men than in women. The other portion of the larynx is the cricoid cartilage, which is a firm ridge that is inferior to the thyroid cartilage. So one thing I suggest is that you review inferior, posterior, anterior, etc. Make sure that you remember these terms so that you remember what portion of anatomy is in relation to another portion of the anatomy, and you describe those correctly. Let's look at the incorrect answers. Again, which of the following statements regarding the Adam's apple is false? A. It is inferior to the cricoid cartilage. That is the correct answer. B. It is formed by the thyroid cartilage. That's true. C. It is the uppermost part of the larynx. That's also true. And D. It is more prominent in men and women. And that is true. But the false answer is that it is inferior to the cricoid cartilage. It is not. Question 2. The globe of the eye is also called the A. lens, B. orbit, C. retina, or D. eyeball. This one should be very easy. It is, of course, D. The globe of the eye is also called the eyeball. The lens, which sits behind the iris, focuses images on the retina, which is the light-sensitive area at the back of the globe. The globe is located within a bony socket in the skull called the orbit. We just covered all of these other answers, so I'm not going to review them here. But make sure that you are clear on the definition of lens, the definition of orbit, the definition of retina, and also know that eyeball is another term for the globe. Number 3, when a person is looking at an object up close, the pupils should A. dilate, B. constrict, C. remain the same size, or D. dilate and then constrict. Think about pupil function, and this should be relatively easy. It is B. The pupils, which allow light to move to the back of the eye, constrict in bright light and dilate in dim light. The pupils should also constrict when looking at an object up close and dilate when looking at an object farther away. This is called pupillary accommodation. These pupillary adjustments occur almost instantaneously. Let's look at the incorrect answers. Just to remind you of the question, when a person is looking up at an object up close, the pupils should A. dilate. That's incorrect. The pupils will dilate when looking at objects far away. B. constrict. That's the correct answer. C. remain the same size. That's incorrect because the pupils will constrict when looking at objects that are up close. And D. dilate and then constrict. That's incorrect because the pupils will constrict first when looking at close objects. Question 4. When caring for a chemical burn to the eye, the EMT should A. prevent contamination of the opposite eye, B, immediately cover the injured eye with a sterile dressing. C, avoid irrigating the eye as this may cause further injury. Or D, irrigate both eyes simultaneously even if only one eye is injured. If you use just straight logic, this is very, very simple. It is, of course, A. When irrigating a chemical burn to an eye, it's important to direct the stream away from the uninjured eye. If you do not, you will likely flush the chemical from the injured eye into the unaffected eye. After irrigating the eye for the appropriate amount of time, then you want to cover both eyes with a sterile dressing. So let's look at the incorrect answers. We already established that A is correct. Prevent contamination of the opposite eye by flushing from the inside towards the outside. B, immediately cover the injured eye with a sterile dressing. Putting a sterile dressing on it is meaningless if you don't irrigate the eye first. C, avoid irrigating the eye as this may cause further injury. That's not correct. Irrigation of the affected eye must take place, and then again direct the stream away from the uninjured eye. And D, irrigate both eyes simultaneously even if only one eye is injured. Well, that's not really rational. You want to direct the stream of the contaminated eye away from the unaffected eye, and there's no logic in irrigating an uninjured eye. Your focus should be on the injured eye. Which of the following signs is least indicative of a head injury? A, asymmetrical pupils. B, pupillary constriction of bright light. C, both eyes moving in opposite directions. Or D, inability to look upward when instructed to. This one should also be very obvious. It is B. The pupils normally constrict in bright light and dilate in dim light. Suspect a head injury if the pupils do not react appropriately, if they're asymmetrical or unequal, they do not move together, or if the patient is unable to look upward. Since we covered all the incorrect answers along with the correct answer, I'm not going to review them here, except to say that make sure that you're very familiar with normal pupillary response versus an eye response versus abnormal pupillary and eye response. And here's the rest of number 5, which of course we just discussed as well. Number 6, the purpose of the eustachian tube is to A, move in response to sound waves, B, transmit impulses from the brain to the ear, C, equalize pressure in the middle ear when external pressure changes, and D, house fluid within the inner chamber of the ear and support balance. If you think about why you chew gum in an airplane, this should be a very simple answer. It is C. The middle ear is connected to the nasal cavity by the eustachian tube. This permits equalization of pressure in the middle ear when external atmospheric pressure changes. You also experience the same thing if you go down a mountainside or even up a mountainside. You have the pressure changes in the atmosphere, and that causes pressure changes in the eustachian tube. Let's look at the incorrect answers. Again, the question is, the purpose of the eustachian tube is to A, move in response to sound waves. That's incorrect. This occurs in the tympanic membrane or the eardrum. Of course, those are the same thing. Make sure you're always familiar with not just the everyday term, but the proper medical term. So the eardrum is the tympanic membrane. B, it transmits impulses from the brain to the ear. That's not the purpose of the eustachian tube. Impulses are transmitted from the ear to the brain. C, equalize pressure in the middle ear when external pressure changes. As we talked about at length already, that is the correct answer. Or D, house fluid within the inner chamber of the ear and support balance. That's not the function of the eustachian tube. It's the bony chambers of the inner ear that support balance. Review question 7. When caring for a patient with facial trauma, the EMT should be most concerned with A, spinal trauma, B, airway compromise, C, associated eye injuries, or D, severe external bleeding. Again, the question is, when caring for a patient with facial trauma, the EMT should be most concerned with one of the following. Let's look at the correct answer. It is B. The rationale is if there's no airway, there's no patient. Injuries to the face often cause obstruction of the upper airway, either by clotted blood or associated swelling, or even active bleeding. Additionally, large amounts of blood can be swallowed, which increases the risks of vomiting and aspiration of the vomiting or the vomitus back into the lungs. Bleeding control, spinal trauma, and associated injuries are important factors and should be treated accordingly. However, the airway comes first, and you've covered that in nearly every chapter up to this point. If you have no airway, everything else is moot. So always bear that in mind. Let's look at the incorrect answers. When caring for a patient with facial trauma, the EMT should be most concerned with A, spinal trauma. This is a concern and should possibly be treated, but again, the airway is primary. And of course, B, that's correct also. Airway compromise is your main consideration. You must have a patent airway. C, associated eye injuries. That is a possible concern, but again, airway is the priority. And D, severe external bleeding. That is also a concern, but again, airway is always first. Review question 8. The presence of subcutaneous emphysema following trauma to the face and throat is most suggestive of A, esophageal injury, B, cervical spine fracture, C, crushing tracheal injury, or D, carotid artery laceration. Remember what causes subcutaneous emphysema following trauma to the face, and you'll get the right answer. It is C. Crushing injuries or fractures of the larynx or trachea can result in a leakage of air into the soft tissues of the neck. The presence of air in the soft tissues produces a characteristic crackling sensation, and sometimes you can even hear it, a crackling sound, and that's called subcutaneous emphysema. Let's look at the incorrect answers. To remind you of the question, the presence of subcutaneous emphysema following trauma to the face and throat is most suggestive of A, esophageal injury. That's not correct. This will produce bleeding, which may be observed in the patient's mouth or through difficulty swallowing, but it's not the correct answer here. B, cervical spine fracture. This may be indicated by pain and or paralysis, but will not typically cause subcutaneous emphysema. C, crushing tracheal injury. Think about what the trachea does. Air moves in and out of the trachea. So if the trachea is injured, air is going to leak out, producing subcutaneous emphysema. So C is the correct answer. D, carotid artery laceration. Carotid artery laceration. This could be assessed by excessive swelling or the presence of a large hematoma in the neck area. So make sure that you are very familiar with the complex anatomy and physiology of the neck and the different types of injuries that can result And that's all I have to say about that, except to reemphasize again, please review this carefully. Question number 9. A 21-year-old male has a large laceration to his neck. When you assess him, you note that bright red blood is spurting from the left side of his neck. You should immediately A. Apply pressure dressing to his neck, B. Sit the patient up to slow bleeding, C. Place your gloved hand over the wound, or D. Apply 100% oxygen via a non-rebreathing mask. One thing to make sure you consider here, bright red blood. Bright red blood is arterial blood. So bearing that in mind, let's take a look at the correct answer. It is C. Obviously, you have laceration of the carotid artery, as evidenced by bright red blood spurting from the wound, and this can cause profuse bleeding, profound shock, and death very quickly. And if you recall earlier, that term is called exsanguination. You must immediately control the bleeding with the use of direct pressure. Cover the wound with your gloved hand initially, and then apply a bulky pressure dressing. After the bleeding has been controlled, apply high flow oxygen and transport, not just promptly, super promptly. You must immediately consider ALS upon observation of this type of injury. Let's look at the incorrect answers. Just to remind you of the scenario, a 21-year-old male has a large laceration to his neck. When you assess him, you notice that bright red blood is spurting from the left side of his neck. You should immediately A. Apply a pressure dressing to his neck. That's incorrect. You should apply a bulky dressing to control bleeding, but first you have to apply direct pressure on the bleeding. B. Sit the patient up to slow the bleeding. Again, bleeding must be controlled first with direct pressure. C. Place your gloved hand over the wound. That's the correct answer. Immediately apply pressure and help bring that under control right away, or he's going to bleed to death right in front of you. And D. Apply 100% oxygen via a non-rebreathing mask. That is applied after bleeding is controlled. Okay, so we've pretty well covered this one. Okay, and we finally come to review question 10. Which of the following mechanisms of injury would most likely cause a crushing injury of the larynx and or trachea? A. Attempted suicide by hanging. B. A gunshot wound to the lateral neck. C. A car crash involving lateral impact. Or D. A patient whose head hits the windshield. Think about each of these examples and the anatomy and physiology of the neck, and you will get this answer correct without too much trouble. It is A. Any crushing injury of the upper part of the neck is likely to involve the larynx or trachea. Examples include the anterior neck impacting a steering wheel, hanging or distraction mechanisms, and clothesline injuries. Let's look at the incorrect answers. Okay, just to remind you of the question, number 10, which of the following mechanisms of injury would most likely cause a crushing injury of the larynx and or trachea? A. Attempted suicide by hanging. That's the correct answer. B. Gunshot wound to the lateral neck. This would produce a penetrating injury. Plus, I said to be familiar with these terms, lateral is on the side, and the larynx is not on the side of the neck. C. Car crash involving lateral impact. Again, that's lateral, that's on the side. So this type of injury would cause damage to the spine and possibly the head, but it would be on the lateral aspect or the lateral side. And D, a patient whose head hits the windshield. This would produce an injury to the head or a compression injury to the spine, but not the front of the neck as described in the question. Okay, class, as always, I thank you for your time and attention. There is a lot of tremendously complex anatomy and physiology in the neck. It is extremely important that you are so familiar with it because there are so many different types of injuries that can occur. And of all of the areas of our body, with all of these important structures, there's not a lot of protection. So there's quite a lot of injury that can occur to this portion of the body. So please make sure that you review this review this chapter carefully. Please seek out any advice from your instructor or if you need any type of help. And study hard, and I will see you next class. Thank you again, and I'll see you next class. Bye-bye.